Hello, my name's Florence. Welcome to theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 122, Sepsis. This week, I'm lucky enough that I'm going to attend the Embrace Conference on Maternal Mortality. Embrace stands for Mothers and Babies Reducing Risk Through Audits and Confidential Inquiries across the UK. This is very important. Essentially, Embrace survey the small number of maternal deaths and the slightly larger number of baby deaths across the UK year in, year out. This is crucial work because in a unit you'll see hopefully very few of these deaths, but the information gathered by looking at the aggregate of these cases across the country gives us really valuable information on how to improve and how to prevent deaths. This made me think about talking about sepsis, because for as long as I can remember, sepsis has been up there as a cause of maternal death. Fortunately for us, maternal death in the UK is vanishingly rare. It runs around 9 or 10 per 100,000 maternities. And currently, I'm not sure what they're going to say this week, but the top causes of death have started to be things less directly related to pregnancy and more related to pre-existing conditions, such as cardiac disease or neurological disease or cancer. That doesn't make these deaths any more acceptable or any less tragic, to be clear. But for me, this is good news because this means that the deaths that are perhaps more preventable are reducing. And this is why I want to talk about sepsis today, because essentially sepsis can fall into that category, a preventable death. And of course, for every woman that dies, there are women that get sepsis that survive. So what is sepsis? Sepsis is also sometimes known as blood poisoning, and it's the body's inflammatory response to an infection or injury. Your immune system is supposed to fight infection, but sometimes, for some reason, it's almost like your body overdoes it. You get an infection, and your body's response to that infection is so overwhelming, it starts to attack its own organs and tissues. And if this isn't treated rapidly, sepsis can result in organ damage, organ failure, and death. But the good news is, with early diagnosis, it's entirely treatable, with antibiotics as the mainstay. When I started out as a consultant, I can't remember where, but I heard an inspiring talk by Ron Daniels, the chief exec of the Sepsis Trust. He is an intensive care consultant who has spent his life devoted to raising awareness about sepsis and making it easier and simpler for clinicians to remember what to do. If you've never heard Ron Daniels talk, I suggest you go to the link in the programme notes and have a look at his introduction to sepsis talk. For me, the reason it hit home is I'm a football fan. And he talks about the numbers of deaths from sepsis in the UK each year being roughly equivalent to the capacity of a football stadium. Now, I know what that number of people looks like. I go most weeks and sit in that crowd. I leave with the throng at the end of the match. The thought that that number of people, that vast quantity, roughly 37,000 people, die from what is essentially a preventable cause a year in the UK is overwhelming and shocking. As I mentioned, the Sepsis Trust has pioneered treatment, making it easier for us as clinicians. And for some years, as part of our maternity mandatory training, I've been teaching staff about sepsis, how to recognise it, how to treat it. The Sepsis Trust has done a massive amount of training, and their simple approach has been adopted at many hospitals across the country, including my own. Essentially, the treatment is the Sepsis 6. It makes it easy for us as clinicians to remember what we're doing. The Sepsis 6 pathway breaks down into 3 in and 3 out. 3 things we need to give, 3 things we need to take. And the Sepsis 6 should be done within the first hour. Speed is of the essence. So, let's start with the 3 in. Number 1, oxygen. Number 2, intravenous antibiotics. Number 3, intravenous fluids. So the oxygen, obvious no-brainer, need to get oxygen to the tissues. Keep them alive, keep them healthy, give them the oxygen supply they need. Antibiotics to immediately start fighting whatever the cause of the infection is. And intravenous fluids, because if you're very unwell with sepsis, you can become dehydrated and have low blood pressure. So those are the 3 in. What are the 3 out? First, blood cultures. That's taking blood to culture and look for bacteria. And this is important because you're going to want to pinpoint what the infection is at a later point, if you possibly can, so that you can tailor your antibiotics at a later point. Next out, lactate. A lactate is a look at how acidic or not your blood is. How much lactic acid are you producing? And again, that helps tell us how well hydrated you are and how your body's coping with infection. Are you building up lactic acid or carbon dioxide? And then finally, urine output. So putting a catheter tube into the bladder to measure how much urine your body's producing. That tells us how your kidneys are working, and they're one of your vital organs. So 3 in, 3 out, within an hour. We practice it, we teach on it, we train on it, we have the notices up and about round the hospital. And if you follow me on Twitter or Instagram, you'll see that my picture this week on Instagram is actually our lift doors at the hospital, coated with Think Sepsis, so that it's in our face, we're not going to miss it. So if we're aggressively treating sepsis with this 3 in, 3 out across the hospital What does this mean in maternity? Well, in maternity, unfortunately, I can tell you, I have seen women very, very unwell from sepsis. And some of these infections will be directly related to pregnancy. Maybe the woman's broken her waters prematurely. Unfortunately, amniotic fluid is an absolutely brilliant culture medium for bacteria. They love to proliferate and grow in the amniotic fluid. So it could be directly related to pregnancy. Or a woman postnatally gets an infection. But equally, there are changes in the body's immune system that mean women are more prone to other infections in pregnancy. And the most common infections are actually urine infections and chest infections. Coming back to Embrace, which surveys the rate of maternal mortality, you can see that sepsis is partially a success story. If you look at the figures, deaths per 100,000 maternities from the years 1985 to 2017, you can see that deaths from sepsis peaked in the triennium 2006 to 2008 with 26 deaths from sepsis, and has fallen back down to around 10 deaths from sepsis in 3 years. So the numbers are very small. But let's not forget that those deaths are the tip of the iceberg. More commonly, what we see is women coming in, being unwell, hopefully being treated, and those deaths being prevented. So how do we pick up sepsis? Well, it can be a little needle in a haystack. And I think this can make women feel that we're being quite aggressive when we treat things, or worry that they've had sepsis when actually perhaps they haven't. Because if you look at that 3 in, 3 out, we've got to do those things ideally within an hour. So if we have any doubt or any possible thought that the woman in front of us has sepsis, we will throw antibiotics at her. We will put a drip in her arm. We will catheterise her. We will throw everything at her in the hope of preventing her becoming severely unwell. And we'll write in the notes, query sepsis. Now, this isn't the wrong thing to do, far from it, but it can lead to women coming back to me, perhaps for a follow-up appointment, and saying, did I have sepsis? It says in my notes sepsis. Maybe they've got a copy of their notes, or maybe someone has said to them that we thought they might have sepsis. Most often the answer is no, they haven't. Most of the time it's actually that they've had a severe infection. We've got on top of it, we've treated it quickly, and they either weren't going to get sepsis or we prevented them from getting sepsis. But they didn't get to that point where their body's organs were starting to fail as a result of that infection. They were in an earlier stage. But we have to write down sepsis and we have to think sepsis constantly, because sepsis has a high mortality, both in and out of pregnancy, but is also potentially a preventable mortality. So how can we diagnose sepsis? Part of the problem with sepsis is symptoms can be very vague. I've looked after a number of women with sepsis over the course of my career. And a lot of the time, the realisation that they have sepsis is kind of a gut feeling that there's something not right. Most of the women that I see that have a bad infection, it's kind of obvious. Their heart's racing. Their pulse is high. They may be breathing a bit more rapidly. They've got a high temperature. And whilst, yes, I need to treat these women and worry about them, they aren't actually the ones that I worry about. Some of the women that I have seen that have been most seriously ill with sepsis, it's been a bit more insidious. They've turned up at the hospital, and when asked, they just say they feel generally unwell. They're feeling lethargic. Maybe they talk about feeling a bit achy, flu-like, just not right, but they can't really put their finger on what's happening or why they feel that way. I've had a small number of women that I've admitted they're perhaps in the middle of pregnancy and they're just not totally sure what's quite wrong. And they've come in with some vague aches and pains. And then when I've gone back to see them, half an hour or an hour later, the penny's dropped. They look like an almost entirely different person. And for me, that's always been the thing when I've seen sepsis, is to realise this person is deteriorating in front of my eyes. And it's not their pulse, and it's not their blood pressure, and it's not their temperature. Quite often I've seen women with severe sepsis that don't even have a temperature. It's that kind of grey, looking really unwell appearance. That's what sparks something for me. And it may be that I've already treated them with antibiotics. And it may be that I'd already instituted the correct treatment, but I've suddenly clocked, no, this isn't a bad infection. This is something different. This is where I need my critical care colleagues, and I need them urgently. The speed at which someone with sepsis can deteriorate can be quite shocking. So when I teach about sepsis, which I've done every year on our mandatory training since I started as a consultant, one of the key things I say to the team is go with your gut. Doesn't matter if the woman doesn't have a temperature. She may or may not have a fast pulse. But what's her respiratory rate? How fast is she breathing? Normally a respiratory rate should be around 14 a minute, in and out. If a respiratory rate is 20 or 30, something's not right. And it doesn't mean that she's got a chest problem. It means her body is fighting things and she's needing to breathe at that rate to keep up. So signs and symptoms can be vague, and it's important not to hesitate, but to get on with your 3 in, 3 out, involve your anaesthetic colleagues, involve your critical care colleagues, and get on top of it. Because, yes, most of the women I've seen with sepsis have survived with the right treatment and the right support. It's always a little bit difficult, depending on how pregnant the woman is, whether you treat a woman with sepsis while she remains pregnant, or whether to optimise her treatment, you need the baby to be born. If a woman is going to require ventilation, one can ventilate a heavily pregnant woman, but it's more difficult. The pregnant womb splints the diaphragm, reduces her lung capacity, and makes it increasingly difficult. So in some situations, when a woman is very unwell and you're in the 3rd trimester, you may decide that actually one of the ways of managing the sepsis is actually to deliver the baby. And this is obviously a multidisciplinary team discussion. You need to involve the neonatal team, critical care team, the anaesthetists, the obstetricians, and the family, all to decide what is best for that woman. But for some women earlier in pregnancy, the birth of the baby just isn't an option. It may be that the baby's too preterm. And I have had some women who have been ventilated and severely unwell with sepsis in pregnancy, where we haven't delivered the baby, and the woman has gone on later at full term to have her baby, and both she and the baby have been fine. These cases are rare. These cases always involve much discussion. And I don't just mean with other colleagues from other disciplines. When I've had a woman with severe sepsis, we've often had a conversation, 2, 3, 4 different obstetric consultants too, discussing, given this situation, the one we're in now, with this woman, with what we think is wrong with her, what do we think collectively might be the best thing for her and her baby? Of course, not all outcomes are happy. I've looked after women that have had severe sepsis where sadly the baby has died. The woman's overwhelming infection has been too much for the pregnancy to continue. And then, very rarely, I have seen women, a very, very small number over the course of my 30-year career, die from sepsis. It is a killer. One of the best known causes of maternal death, historically, puerperal sepsis, is due to a bacteria called Group A strep. This is well recognised in history and indeed contributed to the innovation of asepsis and the importance of hand washing and the idea of transfer of infection between patients. As Semmelweis and Lister made observations about medical students performing post-mortems on women who died from infection, and subsequently the women that they saw in the lying-in hospital in Vienna dying too. Despite this historical context, Group A strep remains a threat. It's more common in women who have existing children or work with children, as it's carried as a strep sore throat by young children and is seasonal, being more prevalent in the winter months. It's an innocuous infection for those children, but for a woman who's just had a baby, it can be catastrophic. When there have been reviews by Embrace into Group A strep deaths, the most important learning is often actually not about how we as professionals look after women, but more the advice we give women in that postnatal period about the importance of hand washing, the importance of washing their hands and perhaps going to the toilet, touching their stitches or changing their pad. These small interventions, these are the ones that can make a difference potentially. And obviously, unlike our historical counterparts, we're extremely lucky. We have antibiotics. We can treat this infection before it becomes potentially overwhelming and life-threatening. Slightly worryingly, Researching this topic for today's podcast, I see that there has been a slight rise in the last year in invasive group A strep infections in the UK and in scarlet fever caused by the same bacteria. And this is thought to be because we've had 2 years of COVID restrictions where the cases were probably a little lower. So as we come into winter in the Northern Hemisphere, it's important that we're vigilant, that the women we care for are aware of this potential risk, and that we remember that whilst COVID has been at the forefront of our minds, that we need to be more on the lookout for flu and group A strep once again. Of course, COVID as a cause of maternal death, particularly in unvaccinated women, has really dominated things in the last couple of years. And I'm going to be interested to see what this year's Embrace triennial report says in respect of those cases. We know that vaccination is highly protective and that it's important for women, particularly in the 3rd trimester, to be vaccinated, not only for their health, but for that of their baby, to prevent that preterm delivery that might become necessary should they become severely unwell with an infection. So to end today's episode, my zesty bit. If you're a pregnant woman, don't be fearful of sepsis. We are highly trained to respond to it with our 3 in, 3 out. I think what I want you to know is that if it's written in your notes that you've had sepsis, or we jump on you with antibiotics, a catheter tube, and intravenous fluids when you come into hospital and say you just feel a bit grotty, be patient with us, because we'd rather err on the side of caution and over-treat you just on the off chance that you are someone who is going to develop severe sepsis. But it's more likely that if you haven't ended up in intensive care and you've needed antibiotics and maybe a couple of days in hospital, that actually it was just a bad infection. It wasn't sepsis, even though sepsis might be written in your notes, but that we were being cautious because it's hard for us to know. And hopefully we've prevented you and your baby from getting severely unwell. And as we go through winter, make sure you're meticulous about your hand washing. Remember how you were in the worst days of the pandemic. Regular hand washing with soap and water. Regular use of alcohol gel. That really does help save lives and prevent infection. Even now, as we're coming out of the worst of the pandemic, those habits, those behaviours, they're still beneficial. And take us up on those vaccinations. The flu vaccine, the COVID vaccine boosters, because they can really be life-saving for a small number of pregnant women each year. And if you're a health professional listening to this, well, I hope you've heard of the Sepsis 6. Explore the Sepsis Trust website. It's got all sorts of useful educational resources, videos, podcasts, and things to look at. And don't forget, if you see a woman and you're just not sure what's wrong with her, but you've just got that feeling in your gut, then don't be frightened to mention sepsis. Ask, could this be sepsis? Get her quickly seen and treated, just in case. I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Thank you for listening.